Good evening friends, welcome to my channel Critical Care Basics. In last two lectures we have been discussing about acute pancreatitis. Initially we discussed about etiology, the presentation and the investigations that we get done. In the next lecture we discussed about the assessment of severity and various scoring systems that are used. And now we start with the actual treatment of acute pancreatitis. So now let's begin. In first 24 to 48 hours, the mainstay of treatment is fluid resuscitation. The only effective treatment in the first 24 to 48 hours after the diagnosis of acute pancreatitis is intravenous hydration. Plan moderate intravenous hydration. Now, in last few years, the focus has been shifted from aggressive fluid resuscitation to moderate fluid resuscitation with 1.5 ml per kg per hour fluid with a 10 ml per kg bolus. For example, if the patient has a weight of 70 kg, then we give about 700 ml bolus followed by 1.5 ml per kg per hour infusion, provided the patient has evidence of hypovolemia. With a goal-directed therapy for fluid management, goal-directed means we have to fix goals about the mean arterial pressure, about the urine output and the SpO2, and we have to assess whether these goals are achieved or not. The same point, reassess at frequent intervals in the first 6 hours and then next 24 to 48 hours, especially in patients who are older or in patients with cardiac or renal disease. So this is the recent study in 2022, aggressive or moderate fluid resuscitation. The results are early aggressive fluid resuscitation resulted in higher incidence of fluid overload without improvement in clinical outcome. So the focus has now been shifted from aggressive to moderate fluid resuscitation. The rate of infusion in mild pancreatitis, we start with a bolus of 10 ml per kg provided the patient has hypovolemia, and then give an infusion at the rate of 1.5 ml per kg per hour. The evidence of hypovolemia will be BUN more than 25 or HCT more than 44, or the patient has acute kidney injury. We can give fluids more aggressively in young patients who are less than 40 years of age and patients with alcoholic etiology. If the patient has moderate or severe pancreatitis, then we can give a bolus of 10 to 20 ml per kg in 1 to 2 hours and the infusion at the rate of 1.5 to 3 ml per kg. Higher in patients of hypotension. What are the goals? The goals are to keep mean arterial pressure more than 65 and urine output more than 0.5 ml per kg per hour. So you have to keep assessing this every hour, and the hematocrit should be less than 44% and BUN should be less than 25% at 12 and 24 hours. So we have to use these parameters to guide our fluids. In patients who are very sick, invasive monitoring and dynamic parameters are needed in ICU in patient with cardiorenal dysfunction. The fluid resuscitation usually lasts for 24 to 48 hours. Infusion can stop after 24 hours if the patient has mild acute pancreatitis. Which fluid? The fluid of choice for rehydration is isotonic crystalloid solution, either NS or balanced solution or RL or Hartmann solution. NS and RL are more widely used as the first line solution in acute pancreatitis. The chloride concentration of NS is 154 milliequivalents, which is much higher than the chloride concentration of ringer lactate, which is 109. So infusion of NS can cause hyperchloremic metabolic acidosis. Hyperchloremia causes significant reduction from baseline in mean renal blood flow. So in essence, we avoid NS and give ringer lactate. Chloride also may increase renal inflammation and impair renal perfusion. So we prefer either a balanced solution like plasmalide or ringer lactate. Colloids should be avoided. No demonstrable benefit. So colloids have no demonstrable benefit in terms of decreased mortality, and possibly they increase the risk of organ failure. Use of heterstarch has no survival benefit and it increases the risk of renal replacement therapy. So use of starch is no longer recommended. Human serum albumin infusion has no proven benefits. Even albumin has no proven benefits and is associated with longer hospital and ICU stays. So neither starch, hetastarch or albumin. Interestingly, outcomes were unaffected by initial serum albumin levels, infections and total amount of or initial timing of infusion. So the outcome of acute pancreatitis does not depend on the initial albumin level. So if you see albumin around 2.9 or 3.1, don't go and jump to give albumin. Watch for acute tubular necrosis. If the patient has low urine output, assess whether the hydration is actually low or the patient has already developed ATN. Low urine output may reflect the development of acute tubular necrosis rather than persistent volume depletion. In that setting, aggressive fluid replacement can lead to peripheral and pulmonary edema without improving the urine output. So if the patient, keep on assessing the patient. If the patient has decreased urine output, confirm that patient is actually hypovolemic and not the patient of acute tubular necrosis. Fluid resuscitation usually continues for 24 to 48 hours. Continued aggressive fluid resuscitation more than 48 hours may not be advisable, as overtly vigorous fluid resuscitation is associated with increased need for intubation and increased risk of abdominal compartment syndrome. So do not give fluids for more than 24 to 48 hours aggressively, otherwise there may not be mortality benefit. In fact, you will increase the problems. The second important treatment part is the pain. So abdominal pain is often the predominant symptom in patients with acute pancreatitis and should be treated with analgesics. Uncontrolled pain in itself can contribute to hemodynamic instability. Adequate fluid resuscitation is also important in controlling pain, as hypovolemia from vascular leak and hemoconcentration can cause ischemic pain and resultant lactic acidosis. So two important points. First, pain can cause hemodynamic instability. Secondly, hypovolemia can itself cause pain. The most important drugs that are given are opioids. They are safe in providing pain control in patients with acute pancreatitis. We use fentanyl 20 to 50 microgram bolus followed by infusion 10 to 30 microgram per hour. Monitoring. Patient with acute pancreatitis should be monitored closely for first 24 to 48 hours. You have to watch for organ failure. Patient with organ failure will need ongoing monitoring for other complications that might arise. Vital signs including SpO2. You have to give FiO2 so that the SpO2 is at least more than 95%. If the SpO2 is dropping to less than 90, get an ABG done as per clinical situation. Hypoxia may be due to atelectasis. Hypoxemia may be due to atelectasis, pleural effusion, opening of intrapulmonary shunts or ARDS. So accordingly treat the patient. Urine output should be measured hourly and fluid should be given to maintain a urine output more than 0.5 to 1 ml per kg per hour. Also monitor electrolytes. Electrolytes should be monitored frequently in the first 48 to 72 hours, especially during aggressive fluid resuscitation. Apart from sodium potassium, hypocalcemia should be corrected if ionized calcium is low. You have to get serum calcium as well as ionized serum calcium, and if the ionized serum calcium is low, you have to correct. Or if there are clinical signs of neuromuscular irritability like Chowstick of Trossio signs, then correct calcium. Low magnesium levels can also cause hypocalcemia and they should be appropriately corrected. Glucose. Serum glucose level should be monitored hourly in patients with severe pancreatitis and hyperglycemia. Blood glucose greater than 180 to 200 should be treated as they can increase the risk of developing secondary infection. Hyperglycemia can result from parenteral nutrition or decreased insulin release or increased gluconeogenesis and decreased glucose utilization. So multiple causative factors for hyperglycemia. Important thing is you have to keep the sugar at 140 to 180. If it goes above 180 to 200, there is a chance that patient may develop secondary infection. Watch for abdominal compartment syndrome. So abdominal compartment syndrome is a serious complication of acute pancreatitis. It is defined as sustained intra-abdominal pressure of more than 20 millimeter of mercury or plus a new organ dysfunction. So there should be two things: sustained increase of intra-abdominal pressure more than 20 millimeters of mercury plus evidence of organ dysfunction. So there are several deleterious consequences of elevated intra-abdominal pressure on end organ function, including respiratory. So patient can go in hypoxemia, or patient can develop ARDS, or the diaphragm gets pushed up and therefore patient can be dyspneic. There could be hypotension, gastrointestinal disturbances, neurologic disturbances, and renal failure. So patient initially abdominal compartment syndrome may present as hypoxemia and decreased urine output. It is estimated that 15% of patients with severe acute pancreatitis will develop abdominal compartment syndrome, and if the patient develop abdominal compartment syndrome, the mortality is very high. So just two pictures of CT cuts of abdominal compartment syndrome. This is a typical round belly sign in which the AP diameter divided by the transverse diameter is more than 0.8. So you can see the whole abdomen has become a round belly. So this is a sign that the patient has developed abdominal compartment syndrome. In this patient, this is a CT from patient of abdominal compartment syndrome. You can see bilateral inguinal hernia as well. So if you see such round belly sign plus clinical features, increased pressure, then think of abdominal compartment syndrome. Measuring intra-abdominal pressure is not that difficult. We usually do not measure, but it is very simple. You have to use a Foley's catheter with 3 lumen, 3 connections, and you can connect one to manometer, and you can measure the pressure from the level of the bladder. So very simple. If it is more than 20, you can easily diagnose the patient of abdominal compartment syndrome, provided there is organ dysfunction. Regarding nutrition, patients with mild pancreatitis can often be managed with intravenous hydration alone, since recovery occurs rapidly, allowing patients to resume oral diet as soon as possible. If there is no significant nausea and vomiting, so you start with IV fluids only, and as soon as the patient becomes comfortable, the patient doesn't have nausea, vomiting, and the patient doesn't have paralytic ileus, bowel sounds are good, you can start oral feedings. Nutritional support is often required in patients with moderately severe acute pancreatitis, because they are unlikely to resume diet for 5 to 7 days. Nasojejunal tube feeding with elemental or semi-elemental formula is preferred than total parenteral nutrition. Like we just discussed, in absence of ileus, nausea or vomiting, oral feeding can be initiated within 24 hours as tolerated if the pain is decreasing and the inflammatory markers are improving. Start with a low residue, low fat, soft diet, provided there is no evidence of ileus or symptoms, and then advance the diet cautiously as tolerated. Early refeeding with solid low fat diet when the patients are subjectively hungry. There are patients with mild pancreatitis who feel that they are hungry, so they can be started on oral diet regardless of resolution of abdominal pain and normalization of pancreatic enzymes. So even if the enzymes are not normalized or the pain has not totally subsided, if the patient is subjectively feeling hungry and comes in the category of mild pancreatitis, we can start oral feeds. In severe acute pancreatitis, oral feeding may not be tolerated due to postprandial pain or nausea or vomiting related to GI inflammation, or there could be extrinsic compression from fluid collection. So in that case, such patient require parenteral feeding, such patient require enteral feeding if they cannot tolerate oral feeds by day 5. Enteral nutrition rather than parenteral nutrition is recommended in patients with moderately severe and severe pancreatitis who cannot tolerate oral feeds. In patients with predicted severe or necrotizing pancreatitis requiring enteral tube feeding, either nasogastric or nasojejunal tube would be preferred. We also initiate enteral feeding when it becomes clear that the patient will not be able to tolerate, consume nourishment by mouth. Example, the patient is being transferred to ICU, or the patient develops organ failure or SIRS more than 48 hours. So this assessment can usually be made by 5th day. So if the SIRS criteria, more than 2 criteria for more than 48 hours, or the patient is dropping clinical status, being shifted to ICU, then we know that this patient is not going to tolerate oral fluids and will require enteral feeds. Enteral feeding via nasojejunal route requires a radiologic and endoscopic placement. So we have to use an endoscope to place the tube with the help of radiology and endoscopy into the jejunum. Start enteral feeds with a polymeric formula at 25 ml per hour and advance as tolerated, so that at least 30% of calculated daily requirement. Daily requirement is calculated by approximately 25 kilocalories per kg of ideal body weight. So at least 30% of this requirement should be fulfilled with the enteral feeds. Signs that the formula is not tolerated. So when do you think that the formula is not being tolerated? Include increased abdominal pain. Whenever you give feeds, the abdominal pain is increasing, or the patient has vomiting with nasogastric fluid, or the patient has bloating or diarrhea. Here diarrhea is defined as more than 5 watery stools or more than 500 ml in 24 hours, excluding clostridials, deficit toxin and medication induced diarrhea. Right? So if the patient doesn't have clostridial infection and no medicines which cause diarrhea, still the patient has more than 500 ml of watery diarrhea in 24 hours. So this is the sign that the patient is not tolerating oral enteral formula. Enteral nutrition is preferred because it maintains intestinal barrier and prevents bacterial translocation from the gut. So again, advantage of enteral nutrition is avoidance of complications associated with parenteral nutrition, including those secondary to the venous access that is required, and bloodstream infections. The presence of fluid collection and elevated pancreatic enzymes is not necessarily a contraindication for enteral feeds. Okay, so even if you see fluid collections in the CT scan or the amylase lipase have not normalized, you can still, if the patient is clinically better, stable, you can still give a try of enteral feeds. However, in a subgroup of patients, there is clear correlation of pain or recurrence of pancreatitis or worsening of fluid collections with the feeding. So in some seriously ill patients, whenever you give enteral feeds, they have increased pain or bloating or worsening of fluid collections. These are the patients who will require parenteral nutrition. So parenteral nutrition is initiated only in those patients who do not tolerate enteral feeds and the target rate of enteral feeding is not achieved within 48 to 72 hours. What is the target rate? At least 30% of the calories should be fulfilled with the enteral feeds. Use of parenteral nutrition as an adjunct to enteral nutrition is no longer recommended. So it may be actually harmful. So just don't give partial parenteral nutrition, like something like that. The second important point is antibiotics. Up to 20% of patients with acute pancreatitis develop an extra pancreatic infection. So the patient with acute pancreatitis will require antibiotics only if there is an evidence that the patient has some extra pancreatic infection like bloodstream infection, pneumonia or UTI. Extra pancreatic infection are associated with increase in mortality. So when such infection is suspected, antibiotic should be started while the source of the infection is being determined. So get cultures before starting antibiotic. If the cultures are negative and there is no obvious source of infection is identified, remember to de-escalate or discontinue antibiotics, because prophylactic antibiotics and selective decontamination of gut are not recommended in patients with acute pancreatitis. So just because the patient has pancreatitis or you can see a fluid collection in the CT scan does not mean that you have to give antibiotics. Regardless of the type of interstitial, whether it is interstitial edematous pancreatitis or necrotizing pancreatitis, you do not have to give antibiotics as a prophylaxis. Or disease severity, even it is mild, moderate or severe pancreatitis, if there is no evidence of infection, do not give antibiotics. So we will continue these lectures on pancreatitis. In the next lecture, we will discuss about treatment of complications of acute pancreatitis. If you are liking these lectures, please like, subscribe and share. Bye-bye.